Okay guys, welcome back today. Now in this today's class, let's begin with the respiratory pathology. Okay. So now without any further late, let's begin. Respiratory pathology. Right? See, in this respiratory pathology, especially for your exams, the most important topic is obstructive lung diseases. Okay, obstructive lung diseases, sir. Respiratory pathology. Today I'm going to mainly deal with the obstructive lung diseases. Okay. We'll be discussing about the obstructive lung diseases. Tomorrow we'll be discussing about the restrictive lung diseases, lung cancers, and congenital anomalies of the lungs. Okay, all these topics will be discussed in today's class as well as tomorrow's class. But in this today's class, I will be mainly concentrating on obstructive lung diseases. Okay, having said that, now let me do the classification here. So obstructive lung diseases. Okay, how many types are there? Sir, look here, the obstructive lung diseases. Now I'm classifying them into three types. For example, COPDs, chronic obstructive lung disease, pulmonary disease. Chronic obstructive pulmonary disease, COPD. Second one is asthma. And third one is bronchiectasis. Okay, bronchiectasis. Okay. So COPD, asthma and bronchiectasis, all these three are coming under obstructive lung diseases. Under COPD, there are emphysema and chronic bronchitis. These are chronic diseases. Okay, these are chronic obstructive pulmonary diseases. Okay, so emphysema and chronic bronchitis. So generally, what are obstructive lung diseases? Sir, obstructive lung diseases are COPDs, asthma and bronchiectasis. There is obstruction in the airway. There is obstruction in the airway. For the flow of air, there is obstruction in the obstructive lung diseases. Okay. So let me write here, note, in obstructive lung diseases, there is resistance. For what? For the flow of air. For the flow of air, there is resistance. Especially if you ask me, sir, in obstructive lung disease, what's the main problem? Is it the inspiratory problem or expiratory problem? The main problem is with the inspiration or expiration. See, in obstructive lung diseases, the main problem, okay, is going to be with the expiration. The main problem is with the expiration that we will discuss. Okay, remember, in obstructive lung diseases, the main problem is with the expiration. Having said that, without any further delay, let's begin with the topic of asthma. Okay, asthma, sir. Now, asthma. See, asthma is obstructive lung disease. Okay. Now, sir, in this asthma, what happens? See, there is bronchoconstriction. There will be bronchoconstriction. Reversible or irreversible? Asthma, there is bronchoconstriction. There is reversible bronchoconstriction. Why? I will explain you. There is reversible bronchoconstriction, or you can say there is chronic relapsing. Okay, so this asthma, it is an example of chronic relapsing, again and again it will occur. Okay, relapsing inflammation. Okay, it's a chronic relapsing inflammatory condition. So chronic relapsing inflammatory condition, so this asthma, okay, where there is reversible bronchoconstriction, there is going to be reversible bronchoconstriction. Okay. Now, if you ask me, what are the genetics involved in this condition? Sir, is there any genetics involved? Like, which people can get this asthma, sir? See, let me write here, genetics. So the genetics which are seen in these patients who are having this asthma is interleukin 13 gene polymorphism is observed. Okay, so interleukin 13 gene polymorphism. Okay, so remember it's the interleukin 13 gene polymorphism which is observed in these patients, and not only that, there is one more gene polymorphism which is called as ADAM 33. Okay, ADAM 33 gene polymorphism. Okay, ADAM 13 gene polymorphism, ADAM 33 gene polymorphism and interleukin 13 gene polymorphism is going to be observed, is observed in these patients who are having asthma, sir. Now let me tell you what exactly happens in this asthma. Now imagine I am the patient who is having these gene defects. Okay, now I am a individual, or I am a predisposed individual, sir. Okay, I am having some gene problems. Now look, whenever I was exposed to some dust particles, dust or pollen particles for the first time in my life, see what happened. So there is this allergen. Okay, allergen. This allergen might be a dust or pollen. Okay, allergen or pollen I have exposed. Problem is my body recognizes this dust or like pollen as an antigen. So normally they are not antigens, they are not bad substances. Okay, but my body is recognizing this pollen as an antigen. Okay, usually normal people, if they go into some garden, there will be pollen grains will be there. Okay, the flower thing, the pollens. Normally, if the pollen enters into my body, normally what happens, the pollen grains, which are nothing but the proteins, carbohydrates, they will be totally degraded into amino acids, okay, and also glucose in the lungs itself. But there are certain group of individuals, okay, who will recognize this dust or pollen as allergens or antigens. So what they will do? So these persons, for example, this person, okay, who is having all these problems, like the genetic alterations, now he produces the antibodies. Which antibodies? IgE antibodies. Okay, IgE antibodies. He produced IgE antibodies for the first time. Now these IgE antibodies, where they will go? The IgE antibodies, they will go and they will sit on the cells. Okay, they will sit on the cells. So what are these cells? These cells are called as the mast cells. So on the surface of mast cells, which antibodies are present? This is the mast cell. Okay, remember, this is a mast cell, sir. Now on the surface of mast cell, what do you have? These antibodies, which are IgE antibodies, are present. Now these mast cells, where they are present, sir? Now these mast cells, they are present in your respiratory tract. Okay, now these mast cells are present in your respiratory tract, sir. The connective tissue of your respiratory tract. Now for the second time, they go, now for the second time, now when you are exposed to the same things, there is a chance that you can the person can expose it to the dust and pollen grains again in his life. So this allergen, next time, for the second time, when it enters into the body, what this allergen will do? The allergen will come and bind with this antibody, because these antibodies are produced against the pollen. So these antibodies are now getting cross-linked. Now these pollen grains, these allergens, what they will do? They will cross-link. Okay, or simply saying they will activate the mast cells. So the allergen cross-links the IgE antibodies on mast cells. So now what these mast cells are doing? Now these mast cells are activated. So the IgE antibodies are getting cross-linked. So the mast cells are going to be activated. So now these activated mast cells, what they will do? The mast cells degranulate and release what? Degranulate. Degranulation means inside the mast cells there are certain granules present. Inside the mast cells there are certain granules present which contains the histamine. Now whenever there is IgE cross-linking that is occurring, the granules are going to be released. The granules are going to release this histamine. This is called as a degranulation. So mast cells degranulate and release histamine. Now what this histamine will do? What do you think? The histamine is a bronchoconstrictor. Okay, it's a bronchoconstrictor. Okay, so bronchoconstriction is going to happen. Okay, done, simple. So bronchoconstriction is going to happen. So the person will feel difficulty, okay, in taking the air. In asthma, it will be difficulty in taking the air, sir, in asthma. Okay, so this is the the pathogenesis. The allergen is going to, see, the allergen is going to crossing the IgE antibodies which are present on the mast cells. Mast cell activation, mast cell degranulation, histamine release. Histamine causes reversible bronchoconstriction. Okay, reversible bronchoconstriction. Okay, so asthma, it's obstructive lung disease. Okay, there is obstruction. See, bronchoconstriction is obstruction, right? Bronchoconstriction is obstruction. So it's an example of obstructive lung disease. It's a reversible condition. It's a chronic condition. It will occur again and again. And it's an example of which type of hypersensitivity reaction? What do you think? It's an example of which type of hypersensitivity reaction, sir? See, it's an example of type 1 hypersensitivity reaction, sir. Okay, type 1 hypersensitivity reaction. It's an example of type 1 hypersensitivity reaction because remember, type 1 hypersensitivity reactions are allergies. Okay, type 1 hypersensitivity reactions are allergies, okay, atopy, okay, anaphylaxis, all these are the allergy conditions, right? Allergy conditions. So, this asthma is an example of type 1 hypersensitivity reactions because, see, all this immune dysfunction is happening on the surface of mast cells. Okay, the mast cells are involved. So, in type 1 hypersensitivity reactions, which cells are involved? Mast cells are involved. Which antibodies are involved? IgE antibodies are involved. Release of histamine leading to bronchoconstriction. It's the immune problem, sir. It's the immune related problem. Okay, unnecessarily the immune system is recognizing this stupid, simple, these dust particles as antigens. Normally, if dust enters into my body, what will happen? Just I will have a cough and that's it. But in certain people, this dust is recognized as an antigen. The pollen is recognized as an antigen. So it's an immune problem. So that's why hypersensitive reaction type 1. Immune system is doing overaction. Type 1 hypersensitive reaction, sir. Okay. So that's the one important point which I want you to know. Apart from this, what else you should know is for your exam, sir, in this condition, there is hyperreactive bronchial smooth muscles. Okay. The bronchial smooth muscles also, these questions are very important. Hyperreactive bronchial smooth muscles. So there is some problem with the smooth muscles also. The smooth muscles which are surrounding the bronchus, they are also hyperreactive. Okay, whenever the histamine comes on, touches there, so immediately they will undergo, like, that's contraction. The smooth muscle contraction will lead to bronchoconstriction. So these smooth muscles are hyperreactive smooth muscles. Okay, that's the one thing. Hyperreactive bronchial smooth muscles are seen in which disease? Hyperreactive bronchial smooth muscles are seen in which disease? Asthma. And in this condition, not only that the smooth muscles are hyperreactive, but their glands will also, okay, the glands will also do over secretion, sir. Hyper secretion of the mucus. So in a patient who is having asthma, not only bronchoconstriction is there. See, bronchoconstriction is decreasing the lumen. Not only that, in asthma patients, the glands, whatever is there in the bronchus, the glands, they will over secrete the mucus. So what the mucus will do? The mucus is going to further block the airway passage. Okay, so there is hyper secretion of the mucus, right? Hyper secretion of mucus. So hyperreactive bronchial smooth muscles, hypersecretion of the mucus, both of them, they are responsible for reversible bronchoconstriction. Okay. So with this, the general topic, okay, this general introduction is completed. Now, if you look at this patient who is having this asthma, imagine I am a patient who is having asthma, sir. Now, there is more mucus production is there in my respiratory tract, more and more mucus is getting produced. So now I will be coughing. Okay, when I am coughing, sputum will come, right? So now you collect the sputum. Okay, just collect the sputum and you put it under the microscope. Okay, just collect the sputum and put it under the microscope. What you will find? So look here, sputum. In the sputum, what you will see is, in the sputum you will see 3C bodies. Okay, in the sputum, what you will see is 3Cs. 3C bodies are seen. What are the 3C bodies, sir? Any idea? One thing is Charcot. Okay, Charcot laden crystals. So in the sputum, under the microscope, what you can see is this crystal-like appearances. Okay, so these are called as Charcot laden crystals. Okay, Charcot laden crystal. And also you can see this kind of appearance. So what exactly are these? These are called as creola bodies. Okay, creola bodies. And last one, are you able to appreciate this spiral shaped thing which is there in the mucus? These are called as Crushman's spirals. So one C, second C, and third C. So three C's are going to be seen in the sputum. Three C's are going to be seen in the sputum. So what are these charcoal-laden crystals? Creola bodies and Crushman spirals. Now questions which were asked in the exam are, so these charcoal-laden crystals are made up of what? What exactly are these charcoal-laden crystals? So the charcoal-laden crystals are made up of a substance called as galactantin. Okay. Galactantin. Okay. It's made up of galactantin. Now, what are these creola bodies? What are these creola bodies? Creola bodies are nothing but the epithelial cells. Okay, epithelial lining. Epithelial lining will be there, right? So these creola bodies, they are nothing but epithelial cells. Epithelial cells. And last one, the Crushman spirals. Okay, these Crushman spirals, they are made up of mucin. Okay, so the three important C's which are present in the sputum are charcoal-laden crystals, creola bodies, and Crushman spirals. Many times this question has been asked in the exam. Now, one more important thing. You will take the sputum, right? You will going to collect the sputum. Okay, for examination, you are going to collect the sputum. First, you need to fixate the sputum. Okay, first fixate it. Fixation. First fixation. Later, or you will take it and put it under the microscope and you will check it. What is the fixative used? What is a sputum fixative that is used? Okay, so the sputum fixative that is used is called as Saccomono fixative. Okay, so sputum fixative. Let me write here. Sputum fixative, which is used, is called as Saccomono. Okay, look here, Saccomono. Okay, mano fixative. So Saccomono fixative is used for sputum fixation. Sputum fixation. Now, after this, what else you should know for your exams? What else you should know? Look here. This is the healthy on one side. Okay, on my left side. Okay, for example, here. For example, this one. Okay, on this side, I'm showing you the normal airway, sir. Normal healthy airway. On my right. Okay, left and right. Here, I'm talking about the airway in asthma. So, is it normal or not? In both the cases, is it the same? Definitely not. This is the normal healthy respiratory tract. Here, what happened? Sir, there is asthma. The patient is having asthma. So, there is something changed, right? The airway is not the same. So, this is called as airway remodeling. So, what happens? Exact question. Airway remodeling is seen in bronchitis, like chronic bronchitis, emphysema, asthma, something like that. Okay, there is airway remodeling. Okay, there's going to be airway remodeling. Okay, airway remodeling. So, what exactly is this airway remodeling, sir? What exactly is happening in the airway remodeling? There is hypertrophy and hyperplasia of the mucus gland. First one, look here. So, these are the mucus glands. Okay, see here. This is the normal epithelial lumen. Here, there is hypertrophy and hyperplasia of the mucus secreting glands. Okay, that's the one change. Okay, so here goblet cell hyperplasia. What is goblet cell hyperplasia? Goblet cell hyperplasia, goblet cells are the mucus producing glands. Okay, so when compared to the normal, here there is goblet cell hyperplasia. So first thing, in airway remodeling, there is hypertrophy and hyperplasia of mucus glands. That's the goblet cells. Okay, next, what else? Second one, there is increased deposition of subepithelial under the epithelium, subepithelial collagen. Okay, Now look here. This is the normal collagen. Here, whatever the fibers were there, for example, these fibers, the blue color fibers, these are the normal fibers. Little fibers are there. But look here, how much collagen is there? Okay, see, there is so much amount of collagen, so much amount of collagen. See, there is increased collagen. The airway wall is going to become thickened, stiffening from increased collagen, stiffening from the increased collagen. Okay, that is seen. Okay. Next, what else? So hypertrophy and hyperplasia of the mucus glands, increased deposition of the subepithelial collagen, and the third one is increased vascularity. Increased vascularity, more blood flow. See, देखो, more blood vessels. These are the more blood vessels. Okay. But anyway, there is increased vascularity. Okay, there is increased vascularity that is seen in the airways. So these three things which you should never ever forget. Oh my God, there is vascularity. So 99.9% the only question that will come in your exam is airway remodeling is seen in. They won't ask you what exactly is happening in the airway remodeling. What they will ask you is airway remodeling is seen in which it is asthma. That's it, asthma. Airway remodeling is going to be seen. Okay. So this is just image. You can very clearly see here. On one side there is a normal airway. On the other side, airway from patients with asthma. There is a difference. Okay, there is a difference. It's not the same. So here there is a very good lumen. Here what happened to the lumen size? The lumen size decreased. The lumen size decreased. Okay. Now after this, what else I should teach you? Types of asthma, sir. Right? Right here, types of asthma. How many types of asthma are there? Same. The first type of asthma is atopic asthma. Okay, atopic. Atopic means what? Allergy. The general thing, the most common thing, which you already know it, right? Which means like, the allergy to the dust or pollen activates the mast cells causing the degranulation of the histamine, causing the bronchoconstriction. Asthma. That's the one kind of asthma, sir. The second one is non-atopic asthma. Very important MCQ. Non-atopic. So what is the difference between atopic asthma and non-atopic asthma? Sir, atopic asthma is mostly seen in children. Okay, mostly going to be seen in the children. And so here, which antibodies are involved? IgE antibodies are involved. IgE antibodies cross section. Okay, so the patient is going to have increased levels of IgE antibodies. Okay, increased levels of IgE antibodies, and it's going to be familial in nature. Okay, familial history. Okay, positive family history will also be present. Okay. Then what are non-atopic asthmas? What are non-atopic asthmas? The non-atopic asthmas are most commonly going to be seen in adults. Okay, they are going to be most commonly seen in adults. Here, these patients are going to have normal IgE levels, normal IgE levels, and see, there is no family history. Family history is usually absent. Okay, history that is negative. Usually, family history, sir. Okay, family history is negative. Examples. Example is very important. Non-atopic. Look, the examples under non-atopic. Under non-atopic, I am writing first. Which condition, sir? Exercise. Okay, exercise, sir. This was the question which was asked in the previous exam. Exercise-induced asthma is which type? Atopic or non-atopic? Exercise-induced asthma is non-atopic. Non-atopic means certain persons who, whenever they do exercise, whenever they will try to do the exercise, only in certain individuals, not everyone, they will start to have asthma. They will start to have asthma. Okay, this is not allergic. There is no something like there is no allergen, nothing. So exercise-induced asthma is an example of non-atopic asthma. Can be seen with cold. Okay, cold, viral infections. Okay, viral infections are drug-induced. So simple, drug-induced asthma. Asthma because of asthma which is seen in the viral infections. Asthma seen which is in cold, or asthma which is triggered because of the exercise, all these are example of non-atopic asthmas. Then what are the examples of allergic, okay, allergic asthmas? Simple, you know it. The name itself it will be there. Allergic. Okay, allergic bronchial asthma. Full form, sir. Full word. Allergic bronchial asthma. Simple because of the allergy, because of the pollen. Okay, and occupational asthma. Occupational asthma means he is doing some occupation, and in this occupation, okay, occupation means he is doing some job, and he is getting this allergen. Every day he is exposed to that allergen again and again, and that's what is causing the asthma. So occupational asthma is an example of atopic asthma. Allergic bronchial asthma is an example of atopic asthma. Okay, atopic asthma. Next, very important thing which was asked in the exam is allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. Okay, aspergillosis. Allergic bronchopulmonary aspergillosis. So it's also an example of, seeing the name allergy is there. Allergic bronchopulmonary aspergillosis. Even this allergic bronchopulmonary aspergillosis, again there's going to be bronchoconstriction is going to occur. Again asthma, same asthma features. So at the end of the day, the only thing which I want you to know is asthma is of how many types? Allergic, non-allergic. Allergic examples, because of some pollen, because of some occupation, because of some infection, which is bronchopulmonary aspergillosis, and others seen in cold, seen with drugs, seen with exercise, okay, viral infection. All these are examples of allergic asthma, sorry, non-allergic asthma. Okay, non-allergic asthma seen in adults. So this is also completed. Now, after this, asthma important topics completed. Just as a recap, what are the important points, only important points which you need to know regarding the asthma? Reversible bronchoconstriction, interleukin 13 polymorphism, Adam 33 polymorphism, okay, type 1 hypersensitivity reaction, mast cells are involved, IgE antibodies involved, histamine causes bronchoconstriction, that is reversible bronchoconstriction, okay. Next, in the sputum you will see three C's, Crashman spirals, Crayola bodies, charcoal laden crystals. Charcoal laden crystals made up of galactantin, Crayola bodies are epithelial cells, and the Crashman spirals are made up of the mucin. So the sputum fixative, which is usually called as a saccomanofixative, bronchial airway smooth muscle remodeling. Okay, airway remodeling is seen in asthma. In airway remodeling, what you will see, there is hypertrophy and hyperplasia of the mucus glands. There is increased vascularity, increased subepithelial deposition of collagen. Okay, increased subepithelial deposition of collagen. Not only that, smooth muscles. Okay, hyperreactive smooth muscles. The number of smooth muscles also increases. See, when compared to here, they go, these are the smooth muscles, bronchial smooth muscles. Here they go, more number of smooth muscles are there. This is hyperplasia of airway smooth muscles. This is also seen. Okay, let me write here itself. Why to simply leave it? There is hyperplasia of airway smooth muscles. There is hyperplasia of airway smooth muscles that's going to be seen, sir. So with this, yeah, asthma completed. The types of asthma also completed. There are two types of asthma. One is allergic asthma as well as a non-allergic asthma. So with this, asthma topic is completed. Now let's discuss about the second obstructive lung disease. The second obstructive lung disease, that is called as bronchiectasis. Okay, that's called as bronchiectasis, sir. Okay, let me write here. Bronchiectasis. Okay. So bronchi here means bronchi, the bronchi. Okay, and ectasia means what? Dilatation. Ectasia means dilatation. So what exactly is happening in this bronchiectasis? Right? It's a pathological dilation. Okay, you can very clearly see here, right? The bronchi are getting too much dilated. The bronchi are getting dilated. Why? The question is why. There is pathological dilation. I will explain you. Pathological dilation, that is permanent or like reversible. It is permanent. It's a permanent, pathological permanent. Okay. So pathological permanent dilation of bronchi. Okay. With the necrosis and destruction. There is necrosis and destruction. Necrosed, dead. The bronchi are going to be totally damaged and they are totally dilated like this. Now they are just holes, just empty air spaces. Okay. Now, what are the causes, sir? Why bronchiectasis? Why? Why the bronchi are pathologically dilated? Why they are undergoing necrosis? Because you need to understand the causes. The causes include congenital disorders. Okay, congenital disorders. First one. What are the which congenital disorders? What do you think? Which congenital diseases can lead to bronchiectasis, pathological dilation of this bronchi? One is cystic fibrosis. Cystic fibrosis. Second one is Cartaginer syndrome. Cartaginer syndrome. In these two conditions, you can see bronchiectasis. Second conditions like infections, like TB infections, or the foreign body obstruction because of some, like, foreign body, like, toy or something, foreign body obstruction, foreign body obstruction. See, in all these conditions, one thing is common, sir. In all these conditions, congenital disorders like cystic fibrosis, Cartaginer syndrome, infection or foreign body obstruction, one thing is common, that's the infection. See, infection here TB, okay. But even in these conditions also, the foreign body obstruction, the infection will start. Okay, there is first blockage. There is a block. In all these conditions, there is going to be a respiratory tract blockage. Respiratory tract is going to be blocked. Whenever the respiratory tract is going to be blocked, automatically infections will start. That's a basic thing in the pathology. Whenever you block something distal to the block, there is going to be development of the infection. Infections will start to develop. Okay, so let me write here. This is also the question which was asked. So first, obstruction, is it going to lead to the infection, or infection will lead to the obstruction? First, you tell me. Obstruction will lead to infection, or infection will lead to obstruction? So write first here. Obstruction can lead to infections. Okay, obstruction can lead to infections. Not only that, infections can also lead to obstruction. This is a question, sir. So what is the event? What is the event? The event can be obstruction or infection. It's the initial event. It can be obstruction, it can be infection, but at the end of the day, infection will lead to obstruction will lead to infection. Okay, so because of this two, what happens is there is necrotizing inflammation. Okay, because of this, there is necrotizing inflammation. Okay, that necrotizing inflammation, the necrosis, the bronchi is going to be necrosed. There is infection. With this infection, there is death of the tissue. Okay, and permanent pathological dilation. So there is bronchiectasis. This was the question asked. What is the first event? The event can be infection or can be obstruction. Okay, can be infection, can be obstruction. At the end of the day, there is a necrotizing inflammation of the bronchi leading to bronchiectasis. Okay, so what are the clinical features? What are the clinical features which are seen in these patients? See, I will explain you about the cystic fibrosis and Cartaginer syndrome. Don't worry. I will explain you what exactly is happening in these diseases like cystic fibrosis and Cartaginer syndrome. But for now, first let's talk about the clinical features. Clinical features. What are the clinical features? See, there is infection in the body. Inflammation is going on in the body. So there will be fever. Second one, there is infection going on. So there will be sputum production. Okay, the sputum production, there's a purulent sputum. purulent sputum, because it's a necrosis is also happening, right? So purulent means pus is also going to form. Okay, so purulent sputum is going to be there, and especially there will be cough during morning. Cough during morning. Okay, so these are some important points which I want you to know. See, the patient who is having bronchiectasis can have the vague symptoms, like fever, nausea, like things, fever. There will be production of the purulent sputum. Why? Because purulent sputum can also be seen in pneumonias. Okay, fever can be seen in many conditions. Okay, these are the vague symptoms. Okay, first question is, why bronchiectasis? I have explained you. The causes here I have explained you, like congenital reasons are there, infections, foreign body obstruction. Okay, see, let's talk about the cystic fibrosis and Cartagener syndrome. Okay, a few important differences between cystic fibrosis versus Cartagener syndrome. Okay, cystic fibrosis versus Cartagener syndrome. Same. What are the differences, sir? Cystic fibrosis, it's an autosomal recessive disorder. That was the question which was asked. Autosomal recessive disorder. The cystic fibrosis, mein, there is a defect of it. There is a gene defect which is called as CFTR gene mutation. CFTR gene is mutated. Okay, because of the CFTR gene mutation, there is defect in the CFTR channel. CFTR channel or chloride channel is going to be defective. Okay, the chloride channel is going to be defective, sir. So because of this, do you know what happens? Because of this CFTR channel, the chloride channel defect, the mucus will become thick mucus secretion. So imagine there is this one baby who is having cystic fibrosis. So the cystic fibrosis baby is going to produce thick mucus, okay, mucus. Now, do you think the thick mucus in the respiratory tract can be easily cleared by the cilia? No, the cilia cannot clear this thick mucus. So what is happening? The mucus is accumulating over there with time. So the what mucus will do? Mucus is growing, and it will cause blockage. There is a block. Now there is a block in that bronchi. Whenever there is an obstruction, you know it. So obstruction will lead to infections. Infections can cause necrotizing inflammation leading to bronchiectasis. Okay, so thick mucus is going to be there. The thick mucus is the one responsible for infections. So in these patients, because of this infection, there is cystic fibrosis. In the cystic fibrosis, patients are going to have bronchiectasis. Okay, bronchiectasis, cystic fibrosis. So done. Now, cystic fibrosis patients, some other features are also going to be there. Cystic fibrosis patients, there are thick secretions are there, right? Thick mucus, thick secretions are going to be there. Apart from the respiratory tract problem, these patients will also have GIT problems. You know what is the GIT problem? Pancreatitis. Okay, the patient will have the pancreatitis, sir. That's also a question. It's a GIT involvement, pancreatitis. And these patients with cystic fibrosis, here itself I am telling you, these patients will have absence of bilateral vas difference. Okay, there is absence of the bilateral vas difference. The vas difference, the sperm pathway. Okay, the sperm pathway. The sperm will come out of the testes into the epididymis from their vas difference, right? In some cases, in some patients with cystic fibrosis, they can have absence of the bilateral vas difference. That's also an important point which I want you to know. Next, Cartagener syndrome. What exactly is the problem with the Cartagener syndrome? Cartagener syndrome का problem क्या है? In the Cartagener syndrome, there is a defect in cilia. Okay, there is defect in the cilia. I should say ciliary proteins. There is this one ciliary protein which is called as dynin. So this dynin, which is present in the cilia, it helps in the ciliary bending. Okay, dynin helps in the ciliary beating. Now, whenever this dynin, it is defective dynin arms, we say. Okay, there is defect in the dynin. So what happens? Cilia will not beat. The cilia are not going to move. So immotile cilia, sir. Immotile cilia. So can I call this as primary ciliary dyskinesia? Yes, true. It's an example of primary ciliary dyskinesia means there is some intrinsic ciliary problem. Cilia में problem है. There is problem in the cilia. Okay, but in cystic fibrosis there is no problem with the cilia. Cilia are okay, but secretions are thick secretions. So that thick secretions cannot be cleared by the cilia, but cilia are normal. Here the problem is it's the primary ciliary dyskinesia. Okay, let me clearly here. So it is primary ciliary dyskinesia. Okay, there is primary ciliary dyskinesia. Because of this primary ciliary dyskinesia, the cilia are not moving. So there are triad of symptoms going to be seen. 3 symptoms are going to be seen, triad of symptoms. Do you know what are they? Sinusitis. Sinusitis, why sinusitis? So in the sinuses also, the mucus is going to be produced. Even mucus production is going to be there in the cilia. Sorry, sinuses. Even the mucus production is going to be there in the sinuses. So usually that mucus is going to be cleared, okay, properly cleared with the help of cilia. But in this patient, the cilia are not beating. So that mucus will come and accumulate in the paranasal sinuses, will block the the drainage of this mucus. So that will lead to infections. So sinusitis, infection and inflammation, sinusitis. And same, the mucus which is getting produced, in the respiratory tract is also not going to be properly cleared because the cilia are not there. So bronchiectasis. Okay, bronchiectasis, because mucus is getting produced, but it is not able to be getting cleared because the ciliary problem, bronchiectasis. So mucus is getting accumulated with time. Infections can occur. Infections will lead to inflammatory conditions. Inflammation can lead to necrosis. So permanent pathological dilation means that bronchi is dead. It's permanently dilated, pathologically dilated. So sinusitis, bronchiectasis, and do you know what is the third thing which is seen? It is called as situs inversus. Okay, situs inversus, which is also called as situs inversus, are the opposite side placement of the organs. Example is the dextrocardia. Normally, during embryogenesis, the heart will shift towards the left. Okay, it will shift towards the left because of the ciliary beating. Your heart, when you are an embryo, is surrounded by the cilia. It's because of the ciliary beating. Heart will shift towards the left side. The apex of the heart will come to the left side because of the ciliary beating. Now in Cartagena syndrome, the defect is in the cilia. It's a primary ciliary dyskinesia. The cilia are not moving properly. When the cilia are not moving properly, the heart which was supposed to be on the left, it will be more placed towards the right. So that's why the name dextrocardia. Okay, that's why the name dextrocardia, sir. So these are some important points which I want you to know. Bronchiectasis is very simple. The permanent pathological dilation of the bronchi, seen with cystic fibrosis and Cartagena syndrome. Also seen with infections like TB, chronic infections like TB, or seen with foreign body obstruction. Some foreign body or a pea nut, some pea, small pea, green peas going, and it's getting the small bronchus. So the bronchus is blocked. Now distal to the blockage, infection will start. Now that infection will cause necrotizing inflammation. So permanent pathological dilation of the bronchi. So differences between cystic fibrosis and Cartagena syndrome also completed, sir. Now after this, okay, the next topic that I want to discuss here is, right, the third obstructive lung disease. The third obstructive lung disease that I want to discuss here is called as chronic bronchitis. Chronic bronchitis, sir. So chronic bronchitis is an example of COPD. It's an example coming under chronic obstructive pulmonary diseases. Now, sir, what exactly is chronic bronchitis, and when can you say that the patient is having chronic bronchitis? When can you say, so this person is having chronic bronchitis? See, the person should have productive cough. The person should have productive cough. Okay, say right now, today night, I am having productive cough. Okay, cough with lots of sputum is coming. Can you say that this patient is having chronic bronchitis? No. So the productive cough is there for how much time? For at least, okay, for at least how much time? 3 months. For at least 3 months in 2 consecutive years. 2 consecutive years. In 2 years span, in 2 years of time, if a patient is having productive cough for at least 3 months, 3 months of productive cough in 2 consecutive years, in 2 continuous years, okay, and excluding all other conditions, okay, excluding all other conditions causing cough. Okay, there is no other reason why this patient is having cough. He is having cough for 3 months continuously in the 2 year span, in a 2 years, in a span of 2 years, simple, in a span of 2 years, if the patient is having cough, it's called as chronic bronchitis. It's called as a chronic bronchitis. Now, if you ask me why chronic bronchitis, sir, what might be the reason? Okay, the reason, the number one reason is smoking, pathogenesis. Pathogenesis is smoking. Chronic smokers, the patient is a chronic smoker, continuously smoking. When you are smoking, what happens? You are taking actually the smoke, the dust particles. So this dust smoking, it irritates. What do you think? Your respiratory tract, is it going to be happy? Is it going to welcome all these dust particles? All the dust particles, please come. Do you think the respiratory tract is going to be happy when the smoke is going? No, definitely not. So the smoking irritates airway. Okay, airway. So in order to remove the smoke, see, lots and lots of dust particles are going into the airway. In order to remove these dust particles, what your respiratory system will do? The respiratory system will try to produce more mucus. So to clear this dust away, so the mucus gland is going to undergo hypertrophy, MCQ. So this irritation of the airway will cause mucus gland hypertrophy. How much hypertrophy? Not a normal hypertrophy set, like too much hypertrophy. Okay, so this hypertrophied mucus glands, what they will do? They increase the mucus, increases mucus production. So that's why productive cough. This mucus is coming out. Okay, that's why productive cough, sir. So increase mucus production. So this increased mucus production is causing productive cough. Okay, see, there is irritation of the airway. The smoke, whatever have gone, it will irritate the airway. So what your body will think generally? Okay, generally you think, sir, what your body is thinking? Array, something bad which is coming into the lungs. Something bad which is coming into the lungs. So just try to take it out. Just try to take it out. How can you take it out? By coughing. By coughing. When you cough, whatever this toxic substance which have entered into the lung, there is a chance that it will come out. But this patient is having excessive amount of mucus production. So that's why productive cough. Cough is there along with more amount of mucus production. Okay, so this mucus gland hypertrophy, okay, this mucus gland hypertrophy, this is the earliest finding. Okay, what is the earliest finding seen in chronic bronchitis? This is the earliest finding. Earliest finding. Earliest finding seen in chronic bronchitis. Okay, and not only that, in these patients continuously smoke. The goblet cells, now they have undergone hypertrophy. They are producing more and more mucus to remove the smoke. See, in the topic, in the first topics and the pathology, in the first topic, we have discussed about cell injury, cell adaptations. Now, imagine you are working under me. I am giving you work, sir. So, if I am giving little work today, you will do it. Now, I am giving more and more work. So, what you will do? You will try to adapt. Okay, you will think that, array, why sir is giving so much amount of work. So, first you will try to adapt, sir. First you will try to adapt. But I am giving more and more work. So, there will be one time you will say, hell with this. Okay, now I am not going to do all this work. So, you will become crazy and you are going to yell at me. Okay, you are going to yell at me. Yelling. Okay, so in the same way, mucus glands are these goblet cells. They will undergo hypertrophy. They will produce more and more mucus. But continuously there is stimulation coming, right? Irritation. So goblet cells will also undergo metaplasia. So goblet cell metaplasia will happen. Goblet cell metaplasia can happen. So this goblet cell metaplasia can be seen. Yes, the goblet cell metaplasia seen. This can increase the risk of, it increases risk of what? It increases the risk of cancer. Increases the risk of the cancer. Okay. Next. After this, what else you should know? Sir, in this patient, what is happening? There is increased mucus production. Sir, do you know what is increased mucus will do? So the increased mucus, okay, the increased mucus, 1 minute. So the increased mucus can block the airways, okay, can block the airways. So whenever there is blockage of the airway, what happens? Infections can start. That infection can lead to inflammation. Bronchiectasis can happen. True, possible. Okay, so mucus production, what it will do is, it blocks the airway. This increased mucus production, more and more mucus is there. It blocks the airway. So when the airway is getting blocked, there is a chance there can be infections. So these chronic bronchitis patients can have infections, true. The question which was asked in the exam is, what is the most common organism? Okay, what is the most common organism leading to this infection? What is the most common organism leading to this infection? This is the question which was asked in the PG exams. Okay, most common organism, any idea? Most common organism causing infection in COPD, that is bronchitis, chronic bronchitis. It is Haemophilus influenza. Okay, Haemophilus influenza, sir, MCQ. It's a Haemophilus influenza which can cause infections in COPD patients. Why infections? More mucus production. Why infection? Why infection? It is a blockage. Why blockage? Because of more mucus production. Why more mucus production? Why more mucus production? Because of airway irritation. Why airway irritation? Because of smoking. Simple, as simple as that. Okay, as simple as that. After this, what else you should know is, sir, in a patient who is having chronic bronchitis, there is increase in the Reed's index. The Reed's index is going to be increased. This is a beautiful diagram that I have found it in the internet. See, Reed's index, it is increased in chronic bronchitis. Now you'll get it out. Sir, what exactly is this Reed's index? What exactly is the Reed's index? I will tell you. The Reed's index, it is thickness of the glands. Which glands? The goblet cells. Okay, the goblet cells, the mucus producing glands. Thickness of the glands to the thickness of the wall. In the thickness of the wall, how much is the thickness of the glands? Okay, look normally here. So these are the glands, these are the glands. Okay, normally some glands are there. This is the entire thickness of the wall. This is the entire thickness of the wall, and this is the thickness of the glands. In the entire thickness of the glands, sorry, in the entire thickness of the wall, how much is the thickness of the glands? A little bit, sir. How much percent? 40%. Okay, 40%. A Reed's index in a normal person is less than 0.4. Less than 0.4 or up to 0.4, that's okay. 40%. That 0.4 means 40%, right? Percentage wise 40%. Fraction is 0.4. Okay. But what happens? The Reed's index in chronic bronchitis, it will be more than 0.4, sir. Why? Look here. What is the thickness of the glands? Thickness of the glands is increasing. Why? I have said you, goblet cell hyperplasia. Okay. More. Look here. In chronic bronchitis, what I have discussed? Mucus gland hypertrophy. Mucus glands are becoming bigger in size. Okay. Even hypertrophy, hyperplasia will occur. More number of mucus producing glands. More mucus. Productive cough. Okay. So Reed's index is increased in which condition? Reed's index is increased in which COPD? Bronchitis. It is increased in bronchitis. It is increased in bronchitis. Okay. Next, what else you should know? In chronic bronchitis, say the statement is, because of the excessive mucus in the airway, because of excessive mucus in airway, what happens? There is excessive mucus in the airway, sir. So that decreases the oxygen exchange. Decreases oxygen exchange. Okay. So because of the excessive mucus in the airway, the oxygen exchange decreases. Because there is a blockage, no, the respiratory tract is getting blocked because of this mucus. So oxygen carbon dioxide exchange decreases. So whenever oxygen carbon dioxide exchange decreases, what happens, sir? So there will be hypoxia. So these patients with the chronic bronchitis can have hypoxia, and the carbon dioxide levels in the body. What happened to the carbon dioxide levels in the body? The carbon dioxide levels in the body also increases. That is called as hypercapnia. Okay. So because of this hypercapnia, the carbon dioxide levels are getting increased. Okay, hypercapnia. What happens? So if you look at this chronic bronchitis patients, they will be having cyanosis, central cyanosis. Okay, central cyanosis. There will be central cyanosis, sir. Hypercapnia means more carbon dioxide is getting accumulated in the body. So there will be central cyanosis. If you look at the lips, blue in color, sir. Okay, central cyanosis. Okay, bluish color. Central cyanosis. So that's why these patients are called as blue bloaters. Blue bloaters, sir. Why? Because they are in blue color. Okay, why blue color? Why the hell they are in blue color? Because of decrease oxygen carbon dioxide exchange. There is central cyanosis. Okay, hypercapnia is seen. Central cyanosis is seen. That's why these patients are called as blue bloaters. Okay, blue bloaters. And what else? What else? Sir, the patient is having hypoxia, right? The patient is having what? The patient is having hypoxia. I hope you have studied this in your general physiology. General physiology. Whenever there is hypoxia in the lungs, do you know what happened to the pulmonary blood vessels? Do you know what happened to the pulmonary blood vessels? The pulmonary blood vessels will undergo immediate vasoconstriction. See, imagine there is hypoxia in my hand. Okay, there is hypoxia in my hand. There is systemic vasodilation. Okay, the blood vessels are going to dilate. But something opposite which happens in the lung is, whenever there is hypoxia in the lung, okay, whenever hypoxia is there in the lung, the pulmonary blood vessels will undergo vasoconstriction. So, right, pulmonary vasoconstriction. Pulmonary vasoconstriction. So the pulmonary blood vessels are now under constriction. The pulmonary blood vessels are under constriction like this. So whenever the pulmonary constriction occurs, what happened to the blood pressure? What happened to the blood pressure in the pulmonary blood vessels? There is pulmonary hypertension. Pulmonary hypertension. So whenever there is pulmonary hypertension, which side of the heart is going to be affected? Which side of the heart is going to be affected? Right-sided heart. So there will be right-sided heart failure. Okay, there is a chance that these patients with chronic bronchitis, can have right-sided heart failure. Why? Simple. Imagine this is the heart. These are the four chambers of the heart. This is the left ventricle. This is the right ventricle. This is the aorta. Okay, this is what? This is aorta, and this is pulmonary trunk. Pulmonary trunk are the pulmonary blood vessel. Now, what I have said you. So there is vasoconstriction, pulmonary vasoconstriction. Whenever there is pulmonary vasoconstriction, there is increase blood pressure over here. So there is pulmonary hypertension. Whenever there is pulmonary hypertension, right side of the heart is going to be affected. So right sided heart failure. So can you tell me what is this condition called as? So because of the pulmonary hypertension, there is right sided heart failure. This is called as what? This is called as cor pulmonale. So this right sided heart failure, this is called as cor, means heart problem, pulmonale. Okay. Sorry. So cor pulmonale, what exactly is cor pulmonale? Cor pulmonale means right sided heart failure because of pulmonary hypertension. Okay. Now, one important point which I want you to know is, say, usually inflammatory conditions, usually any inflammatory conditions, even bronchiectasis also. Okay, let me write here. In bronchiectasis also, these are the questions which were previously tested in the exams. And this one, bronchiectasis, pathological dilation of the airways because of the necrotizing inflammation. Okay, because of the necrotizing inflammation. What are the complications? What are the complications? Sir, usually in lung, inflammatory condition, any inflammatory condition can lead to amyloidosis. The complication, let me write here. Complication is amyloidosis. Okay, amyloidosis. Okay, A type of amyloidosis. This we will study in later. Okay, later topics. Amyloidosis is going to be seen. But chronic bronchitis. Okay, chronic bronchitis, in the name itself it is there. Bronchitis. Okay, inflammation of the bronchi. Bronchitis. The chronic bronchitis does not increases the risk of. There is no risk of amyloidosis. One important MCQ: chronic inflammation. See, chronic bronchitis is chronic inflammatory condition. It's a chronic inflammatory condition. But usually, see, chronic inflammatory condition, any chronic inflammatory condition can increases the risk of, any chronic inflammatory condition can increases the risk of amyloidosis. But yes, chronic bronchitis is a chronic condition, but there is no risk of amyloidosis. Okay? No risk of amyloidosis. There is no risk of amyloidosis. Next, after this, let's directly jump into the next topic, sir, which is called as emphysema. Emphysema. So what exactly is this emphysema, sir? What exactly is happening in this emphysema? See, in emphysema, there is pathological permanent dilation of the acini. Okay, so permanent dilation and destruction of, right? Permanent dilation and destruction of what? Acini. Now we will get it out. What is this acini, sir? Okay, what exactly are these acini? See, this acini, they include, okay, acini, they are a part of respiratory zone, sir. You know it. There will be conducting zone, there will be respiratory zone. Conducting zone is a dead space. Respiratory zone is a place where gas exchange will occur. So, is acini, what exactly is acini? Acini includes respiratory bronchioles, alveolar ducts, and alveolar sacs. Okay, alveolar ducts, alveolar sacs, and respiratory bronchioles. All these three, they will form the acini. Okay, all they will form the acini. So this acini is going to be affected, sir. This acini structure, okay, this acinar airways are going to be affected in emphysema. Okay, so tell me, it's a pathological dilation and destruction. Pathological dilation and destruction of the acinar airways. So in one of the exams, this question was asked. So emphysema, it occurs where? Right, note. Emphysema occurs distal to what? Distal to terminal bronchioles. It occurs distal to terminal bronchioles. Now some students will have a doubt, sir, what exactly are these terminal bronchioles? Why you are saying, like, emphysema occurs distal to terminal bronchioles? Because for this, you need to have a basic understanding. Look here, imagine this is the respiratory tract. Imagine this is the respiratory tract, sir. Now this respiratory tract is divided into two parts. That is conducting zone, respiratory zone. So in the conducting zone, do you know what is the last part? The last part in conducting zone, for example, this part. The last part in the conducting zone is called as terminal bronchiole. The last part is called as a terminal bronchiole. Okay. So after terminal bronchiole, what do we have? Alveolar ducts, respiratory bronchioles. Okay, respiratory bronchioles, alveolar ducts, alveolar sacs. So this is the respiratory zone, sir. So all these three together called as what? Acini. All these three together called as acini. So emphysema is going to affect this part. Okay, emphysema is going to affect the acinar region. So emphysema, it will occur distal to terminal bronchiole. Okay, it will occur after terminal bronchiole, sir. Done. Now, in emphysema, what are the main problems? In emphysema, what are the main problems? Let me tell you. Let me write here. In emphysema, there is elastic recoil, loss of. Okay, why there is pathological dilation? I will explain you. There is a loss of elastic recoil. Okay, there is loss of elastic recoil in the lung. the elastic recoil in the lung is decreased. The elastic recoil, normally lung have to, or the alveoli have to expand and it have to recoil. So expand and it have to recoil. So this recoiling nature is because of elastin fibers. The recoiling nature, it is because of elastin. That elastin is damaged, sir. That elastin is damaged. Okay, that I will one by one I will discuss. But simple, first in emphysema there is loss of elastic recoil. Okay, elastic recoil. Why? Why there is loss of elastic recoil? Because elastin fibers are damaged. Who damages this elastin fibers? These elastin fibers are damaged by proteases. Okay, the elastin fibers are damaged by proteases. Why proteases are damaging these elastin fibers? It's because of smoking. Same, chronic bronchitis can also be because of smoking. Emphysema can also be because of smoking. So true, sir. Smoking can lead to chronic bronchitis. Smoking can lead to emphysema, or the patient can have both chronic bronchitis as well as emphysema at the same time. Possible. Okay. So smoking, what the patient is doing? Smoking, sir. So more and more dust particles are going into the lungs. When more and more dust particles are going into the lungs, what your lung will try to do? What your alveolar macrophages will try to do? The alveolar macrophages will try to remove that dust particles. The alveolar macrophages, by producing enzymes called as proteases, they will try to destroy these dust particles. But these proteases, do you think only they will go and destroy the dust particles? No. These proteases, they will also, now more smokers are smoker, more dust. More dust means the alveolar macrophages are producing more and more proteases. So these proteases, they will also destroy this elastin fibers. So the elastin fibers are damaged. So elastic recoil in the alveolus decreases. The elastic recoil decreases, sir. When the elastic recoil decreases, inspiratory problem or expiratory problem? Expiratory problem. Okay, so elastic recoil decreases. So that's what causes the expiratory problem. Expiratory problem. That's the main problem. Okay, in all the lung diseases, especially in emphysema also, mainly the expiratory problem. So if you look at these patients, okay, if you look at these emphysema patients, so it's the expiratory problem. The alveoli are not collapsing. Elastic recoil is gone. Okay, the elastic recoil is gone. So air is not coming out. So there will be air trapping. There's going to be air trapping. So more air is there in the lungs. So what happened to the size of the lungs? Big lungs, large lungs. Large lungs. Air trapping is going to be seen. Large lungs. The patient is having now large lungs, a big voluminous lungs. So how his chest is going to look like? So his chest is going to look like a barrel. Okay, like a barrel. Barrels, you know, the oil barrels, the containers. Okay, so barrel shaped. Okay, barrel shaped chest. Okay, barrel shaped chest is going to be seen. So when you try to do the percussion, more air is there. When you try to do the percussion, now you feel like you are tapping on the drums because the more air is there. So there will be hyper resonance. Okay, not dullness, hyper resonance. The more sound you can hear. Hyper resonance. Hyper resonance. So air trapping, air is accumulating inside the lung, air is not coming out of the lungs because elastic recoil is gone. So it's hard for the patient to take the air out. So do you know how he will breathe? How he will take the air out? He will try to take the air out something like this, like a puffer fish. You know the puffer fish, right? It's going to have, like, you know how the mouth is going to be. Okay, here it's like more like this, but puffer fish. He will try to take air out forcefully, like a puffer fish. So these patients are called as, these patients do not have, usually there is no inspiratory problem. So no cyanosis. Cyanosis is not seen. These patients are normally, like, you know, pink in color, like, you know, normal oxygenation is happening. So these patients are called as pink puffers. Pink puffers, sir. These patients are called as what? Pink puffers. Their Chronic bronchitis. Chronic bronchitis patients is having central cyanosis. So those patients are called as blue blotters. Those patients are called as blue blotters. Now these patients are called as pink puffers. Why pink? Why the word pink? Because no cyanosis. Why puffer? They are breathing like a puffer fish. They are expiring. They are taking the air out of their lungs. Okay, by doing pursed lip breathing. Okay, like a puffer fish. So that's why pink puffers. Okay, now here I want you to add a few more important points. Look here. Normally, okay, what are the causes of emphysema? Okay, let me put here emphysema. So why emphysema, sir? Why emphysema? I have said you smoking. Smoking, more dust is going into your lungs. So in order to remove that lungs, okay, sorry, in order to remove, not the lungs, sorry, in order to remove the dust particles, what the alveolar macrophages will do? Alveolar macrophages, now they are producing more proteases. Okay, more proteases, not normal proteases, lots and lots of proteases. So now these proteases, what they will do? So these proteases will damage the elastin fibers, will damage the alveolar septa. Okay, so the proteases, let me put it here. What they will do? The proteases will damage elastin fibers. Damaged. Okay, elastin fibers damaged, elastic recoil is gone, that is seen in emphysema. Normally, look here, this is how a normal alveolus will look like. Okay, this is how, like a cluster of grapes. So what is this? This is called as alveolar septa, a thin alveolar septa, sir. Even because of this proteases, this alveolar septa will be damaged. The alveolar septa is also going to be damaged. So do you know how the alveolus is going to look like now? One single alveolus, one single large alveolus, sir. One single large alveolus. Okay, because of the loss of alveolar septa. Why alveolar septa is damaged? Because of the proteases. Okay, because of the proteases. So this is one cause. So smoking is one cause of emphysema, sir. Okay, but this emphysema can be seen. The emphysema can be seen in small children also. Do you think these children are smokers? No, sir. What happens is, normally, let me tell you, the protease activity is going to be controlled. It's going to be controlled. At a protease, you have to work only this much. The protease activity is controlled by antiproteases. Okay, there are certain antiproteases called as alpha-1 antitrypsin. This alpha-1 antitrypsin, okay, it is an antiprotease. It's an antiprotease. Okay, what it will do? It will regulate what? Protease activity. Now, because of some reason, because of some gene mutation, if you have alpha-1 antitrypsin deficiency, okay, you are having what? Alpha-1 antitrypsin deficiency. You are having alpha-1 antitrypsin deficiency. Now, alpha-1 antitrypsin is not there. When it is not there, do you think regulation will occur? Protease activity, the proteases activity, how much they should work. The protease activity is going to be regulated? Not regulated. So what happened to the protease activity? Increases. What this proteases will do? You know it. Proteases causes damage. Proteases causes damage to the elastin fibers. Elastic recoil is going to be lost. The alveolar septa are going to be damaged. So alveolus will become one single alveolus. Okay. So that's what look, given over here. See, look here how the alveolus is. So this alveolar septa are there, sir. Alveolar septa in between the alveoli. There are alveolar septa, but that's lost here. Dekho. How the alveolus become? It's now one single large alveolus because of the excessive protease activity. The protease activity can be increased by smoking, or the protease activity can be unregulated. The protease, more protease activity can be seen in a patient who is having alpha-1 antitrypsin deficiency. Because of that, see, these are the alveolus, sir. This is the, imagine, see, this is the normal lung. Okay, this is the normal lung. But look here, these are the large alveolus. Okay, these are the large alveolus. Okay. Here, small alveolus, normal alveolus. See how beautiful they are. Here they are bigger alveolus, emphysema. Okay, here in this area, emphysema is occurring. Here also you can see how the emphysematous alveoli are large alveoli. Okay, because of excessive protease damage. Now, I have explained you the normal mechanisms in the lung. There are elastases. Elastases means elastase is a protease. Elastase is a protease. Okay, and there are alpha-1 antitrypsin. This is a normal activity, sir. Alpha-1 antitrypsin, it regulates the activity of the elastases. Normally, there is a balance. If there is deficiency, alpha-1 antitrypsin is going down. So, elastases will work more. If they work more, what they will do? They will cause damage. Okay, they will cause damage to the lung tissue. Whenever there is an imbalance, that will cause damage. In normal condition, there is no damage. Okay, so emphysema, I have explained. Look here, here I have explained you. Smoking, what it will do, I have explained you. Okay, so alpha-1 antitrypsin deficiency. Okay, in alpha-1 antitrypsin deficiency, there is antiproteases. Alpha-1 antitrypsin is an antiprotease. So decrease in the antiprotease activity. So more elastic damage leading to emphysema. Okay, and smoking generally in adults, smoking, what it will do? So smoking increases the protease activity. More smoking means more dust. More dust means in order to remove that dust, alveolar macrophages produce more proteases. More proteases cause the damage. Okay, so answer. Now, what else you should know? What else you should know is, so smoking can lead to emphysema, and even alpha-1 antitrypsin deficiency. Okay, alpha-1 antitrypsin deficiency can lead to emphysema. Both emphysema are the same. Both emphysema are the same at gross level, at grassroots level. Do you think both the emphysema are going to be same? No, definitely not. Definitely not. There is some change. There is some change. Let me tell you what exactly is this change. I have found this again in the internet. Some beautiful diagram. See, these are respiratory bronchioles, alveolar ducts, and alveolar sacs. You know it, right? Respiratory bronchiole will be there, alveolar ducts and alveolar sacs are going to be there. So there are different types of emphysema. Now look here, the centri-SNR emphysema. Okay, first type of emphysema, which is most common. In the centri-SNR emphysema, who is getting affected? Like only respiratory bronchioles are getting affected. If only respiratory bronchioles are affected, that is called as a centri-SNR. It's in the center, centri-SNR emphysema. The center of the sinus. This whole thing is called as the sinus. Respiratory bronchiole, alveolar duct and alveolar sac. The whole thing is called as one sinus. Okay, so in centri-SNR emphysema, respiratory bronchioles will be affected. Okay, okay. See the second type of emphysema. In second type of emphysema, the respiratory bronchioles are affected, alveolar ducts and even alveolar sacs are affected. So respiratory bronchiole, alveolar duct and alveolar sac. If every damn thing is affected, that is called as pan-SNR. Pan means complete. Pan-SNR emphysema. Pan means complete. Pan means complete. Okay, centri-SNR emphysema, pan-SNR emphysema. And sir, only alveolar ducts and alveolar sacs. Not the respiratory bronchioles, Only alveolar ducts and alveolar sacs are getting affected. Then it is called as paraseptal emphysema. Okay, paraseptal emphysema. So here actually there are 4 types of emphysema, but irregular emphysema is also there. But generally speaking, how many types of emphysema are there? So there are centri-SNR emphysema, paraseptal emphysema and pan-SNR emphysema. The smoking is going to cause centri-SNR emphysema. Alpha-1 antitrypsin deficiency is going to cause pan-SNR emphysema. Very, very important point. Okay, smoking will cause centri. So smoking is looking like S for centri, something like that. So similar kind of sound, right? So smoking causes centri-SNR emphysema. Alpha-1 antitrypsin deficiency will cause pan-SNR emphysema. In centri-SNR emphysema, respiratory bronchioles are affected. In pan-SNR emphysema, respiratory bronchiole, alveolar ducts, alveolar sac, everything is going to be affected, sir. So if you look at this emphysematous lungs, okay, if you look at the emphysematous lungs, in emphysematous lungs, I have said you, there are the large lungs, big lungs, air trapping, hyperresonance, large volume. Okay, so look at here. Now look at this. These are the normal lungs. Okay, where the lungs are sitting on the proper, that concave diaphragm. Okay. Here, look, the lungs are going to become big. Okay, the lungs are going to be big. So these lungs, what they will do? Now as they are increasing in the size, what happened to this dome shape? Okay, what happened to this dome shape, sir? It's going to become flat. Okay, so there will be flattening of the diaphragm. Okay, there is flattening. Flattening of diaphragms. So there is going to be flattening of the diaphragm, and even you can see here how the lungs are large voluminous lungs. These are example of air trapping. So now tell me, in this condition which is emphysema, what happened to the lung volumes? What happened to the lung volumes and capacities? I hope you have studied lung volumes and capacities. What happened to the lung volumes and capacities? Increases. In emphysema, lung volumes and capacities lung volumes and capacities are going to be increased. Bigger lungs, bigger volumes and bigger capacities, more total lung capacity, more residual volume. Okay, lung volumes and capacities are going to be increased in emphysema. Again, see, this is image where the alveoli are becoming bigger in size. There is a loss of alveolar septa. The alveoli are becoming bigger in size. There is loss of elastic recoil, expiratory problem. Okay, with this, obstructive lung diseases are completed. Now, in tomorrow's class, we'll discuss much more things, the restrictive lung diseases. Also, we'll discuss about the lung cancers and some congenital anomalies. Okay, that will be discussed in the tomorrow's class. Hope the class is helpful. Thank you for good night.